We are going to talk about antibiotic stewardship in Minnesota, skilled nursing facilities, something close to all of our hearts, I'm sure. Sorry, I'm Terry McCarthy, a geriatrician at the University of Minnesota. And I do work for Park Nicollet in subacute transitional care, where we train our family medicine residents in geriatrics. Much appreciate the Park Nicollet connection. Woo-hoo. Our speaker today is Dr. Mohammed Abdullah. He is a CDC Foundation epidemiologist and healthcare antibiotic stewardship lead. This MDH, they've got great titles, at the Minnesota Department of Health, Healthcare Associated Infections and Antimicrobial Resistance Unit. Before joining MDH, Dr. Abdullah was a senior medical advisor at the Embassy of the State of Qatar in Washington, D.C., and the regional manager for Africa at the Susan G. Komen Breast Cancer Foundation. He also served as a consultant for the World Health Organization and UNICEF. Thank you. We appreciate your presence today.
Thank you so much. Good afternoon, everybody. All right. Okay, good afternoon. Today I'll be talking about antibiotic stewardship in Minnesota skilled nursing facilities. So first of all, we'll start talking about antibiotic stewardship and define the CDC's core elements of antibiotic stewardship in nursing homes. And then we'll discuss the results of our 2022 Minnesota survey of skilled nursing facilities antibiotic stewardship practices that we just conducted in June. And we'll also describe the barriers and opportunities for support of antibiotic stewardship programs in Minnesota skilled nursing facilities. So first of all, we'll start it off by, what is antibiotic stewardship? And it's a systemic effort to improve, to measure and improve how antibiotics are prescribed by clinicians and used by patients, so that antibiotics are only prescribed and used when needed. It's not about prescribing less, it's about optimizing and judicious prescribing. So we want to minimize misdiagnosis or delayed diagnosis leading to underuse of antibiotics. And we also want to ensure that the right drug, dose, and duration are selected when an antibiotic is needed. And why is that? As great as antibiotics are and the countless lives they've saved, they do cause harm when not used appropriately. So the first thing is they cause adverse drug events and interactions. And so antibiotics are responsible for about almost 1 out of 5 ED visits for adverse drug events. They also cause antibiotic resistance when not used appropriately. And we have more than 3 million antibiotic-resistant infections occur in the United States each year, and more than 35,000 people die as a result. The third thing is they cause C. difficile infections. And people are 7 to 10 times more likely to get C. diff infections while on antibiotics and the following month. And C. diff is estimated to cause about 500,000 infections in the United States each year, and more than 200,000 people require hospitalizations. The other thing is colonization with C. diff or an antibiotic-resistant organism not only poses a threat for the patient, but also to the other residents because of the transmission, and when residents are also transferred to other healthcare facilities. So that also leads to increased cost of care. So improving antibiotic use is critical to patient safety and reducing the threat of antibiotic resistance. What about antibiotic use in nursing homes? And why it's important? Bless you. So antibiotics are the most frequently prescribed medications in nursing homes. We have about 70% of nursing home residents receive 1 or more of systemic antibiotics in a year. And the astonishing stat is that 40 to 75% of the antibiotics prescribed may be unnecessary or inappropriate. 19% of respiratory tract infections are unnecessarily treated, 65% of those for acute bronchitis, which are about 90% are caused by viral infections. And then when we look at UTI, which is the most frequent indication for antibiotic use in a long-term care facility, a study that was done in 2 nursing home facilities, it's a retrospective study. They looked at prescribing for UTI, and they found that 41% were given for asymptomatic bacteria. And studies have shown that antibiotic treatment for asymptomatic bacteria in nursing home does not confer any long-term benefits, nor does it decrease mortality. And on the contrary, it actually leads to more resistant organisms, and it'll be harder to treat UTIs going forward. They also found that 56% the drugs were inappropriately given, and 67% were excess duration of the criteria for the Infectious Disease Society of America. And so to support nursing homes' efforts to improve antibiotic use, the CDC published the core elements of antibiotic stewardship in nursing homes. These core elements offer providers and facilities a set of key principles to guide efforts to improve antibiotic use and therefore advance patient safety and improve outcomes. So nursing homes are encouraged to work in a stepwise fashion and start gradually and add new strategies from each element over time. And these frameworks complement existing guidelines that we have, from the Infectious Disease Society of America, the Joint Commissions, and others. And so what are these core elements? The first core element is leadership commitment. So it starts at the top. Nursing home leaders need to commit to improving antibiotic use and demonstrate that commitment to safe antibiotic and appropriate use in their facility. How could they do that? Well, first of all, they could write statements in support of improved antibiotic use and share it with the staff, the residents, and the families. They could also include stewardship-related activities in the job description of the medical director, the nurse leads, and the pharmacist. They could also communicate with staff and physicians about antibiotic use and review antibiotic prescriptions in quality assurance meetings. They could also create a culture which promotes antibiotic stewardship through messaging, education, and celebrating improvements and success. The second core element is accountability. After you have your leadership, it's important to identify, physician, a nurse, or pharmacy leads that are going to be responsible for promoting and overseeing the stewardship activities in these facilities. And it's also important to empower the medical director so that they set the standards for antibiotic prescribing and review antibiotic use data and make sure that best practices are followed. It's also important to empower the director of nursing because they set the practice and standards for assessing, monitoring, and communicating changes in residents' condition by the frontline nursing staff. It's also important to engage the consultant pharmacist in supporting antibiotic stewardship oversight through medication review and work with infection prevention coordinator, consultant laboratory, and state and local health departments. The third core element is drug expertise. So after you've showed leadership commitment, identified a leader responsible for a program, establishing access to an individual with antibiotic expertise to implement these antibiotic stewardship activities. And how you can do that is by working with a consultant pharmacist who's received specialized infectious disease training, partner with an antibiotic stewardship lead at the hospitals within your referring network, and also develop relationships with infectious disease consultants in your community. And there's also an opportunity for telestewardship. So this can be done virtually. The next core element is action. And facilities are encouraged to implement at least one policy or practice to improve antibiotic use. And we can go over a few of them here. And like I said, it's recommended that they work in a stepwise fashion and start by implementing 1 and 2 and going through these actions and policies. The first one is antibiotic prescribing use policies. So facilities can develop, they can take action and develop facility-specific treatment recommendations that are based on national guidelines and local susceptibilities, which can optimize antibiotic selection and duration, particularly for common indications for antibiotic use like respiratory tract infections, urinary tract infections, and skin and soft tissue infections. Another intervention that can, or broad interventions to improve antibiotic use can be using the SBAR form, situation, the SBAR form to document information for prescribing clinicians and incorporate this into daily practice. This is important because attending physicians and APPs are not always available on site. And so this is important to give them the information that they need to make optimal and judicious prescribing. Another action that could be taken also is implementing an antibiotic stewardship timeout. And a timeout is actually a core practice in antibiotic stewardship, as they provide an opportunity to make an assessment 48 to 72 hours after starting an antibiotic. After that time, prescribers have more information at hand, laboratory culture and sensitivity results. They can see the response to therapy. So it's a good time to review and see if you're giving the right medication, dose, duration, and others. And EHR, electronic health record systems, can facilitate this timeout process. And some of them actually alert you after 48 to 72 hours to start this process. Another intervention also is pharmacy interventions to improve antibiotic use. And this is also, what we talked about is having access to drug expertise. And so this expertise is critical in reviewing prescriptions to make sure that prescribers use the shortest effective antibiotic duration to avoid and also avoid treatment of things like asymptomatic bacteria. Another core element is tracking. And this is important to monitor antibiotic use and outcomes related to antibiotics. And there's three main things to track. So we want to track antibiotic use, how often and how many antibiotics are prescribed, and this can be done through antibiotic starts and days of therapy. We want to also monitor how and why antibiotics are prescribed by reviewing medical records and seeing adherence to the guidelines. And we'll also want to monitor outcome measures. So we want to track the adverse events and costs from antibiotics. So the rates of C. diff infections, antibiotic-resistant organisms, and adverse drug events. We have the next core element is reporting. And this is to provide regular feedback on antibiotic use and resistance to prescribing clinicians, nursing staff, and other relevant staff. And a study on the effect of educational intervention on optimizing antibiotic prescribing in long-term care facilities showed a 64% reduction in antibiotic use by providing feedback on individual physician prescribing practice and adherence to guidelines. So audit with feedback is a very important tool that can reduce unnecessary antibiotic prescription. And the final core element is education. So it's important to provide resources to the clinicians, nursing staff, residents, and their families, information about antibiotic resistance and opportunities to improve antibiotic use. Effective educational programs address both nursing staff and clinical providers on the goal of antibiotic stewardship intervention. And it's also really important to incorporate both education and feedback to providers. So when we do audit feedback, this can be a great way to include education to providers. So after reviewing the CDC's core elements on antibiotic stewardship, I'll talk now about the survey that we conducted here in Minnesota on antibiotic stewardship practices. During June and July of this year, the Minnesota Department of Health would distribute a survey through a secure online platform to assess antibiotic stewardship practices in core element implementation in skilled nursing facilities. We had a total of 146 skilled nursing facilities complete the survey, so that's about a 40% response rate. And data obtained in the survey will be used to assess and track stewardship over time. So other than this survey, we have access to core element implementation through NHSN data, the National Healthcare Safety Network data, which is the CDC's tool for reporting and tracking healthcare-associated infections. Facilities also complete annual surveys that have antibiotic stewardship core element implementation questions. So we can see kind of over time core element implementation and see progress that's been made. However, this survey kind of just gave us more information into the barriers and areas of support and to specific kind of interventions and specific policies and programs that facilities are doing. So it's also a great opportunity to identify opportunities to support through direct technical assistance and inform development of our MDH-hosted educational opportunities. So what did we find? So in 2022, 80% of nursing homes implemented all 7 core elements of antibiotic stewardship. The highest being leadership commitment at 99%, lowest being education at 89%, and then accountability, drug expertise, action tracking, and reporting were all within 95 to 97%. It's also important to note that if you look on the table on the right side of the screen there, that the facilities that did not implement all 7 core elements implemented, most of them implemented 6. So we have about 16% implementing 6 core elements, and just a few that did not implement, that implemented lower than 6. This graph here shows core element implementation from 2016. And from 2016 to 2021, that's data submitted through NHSN. And the green bar there, that is our survey in 2022. So we can see that from 2016 until 2021, there was great progress that's been made from 22% all the way to 61%. We can see that in 2019, 65% of facilities implemented all 7 core elements, and it went down in 2020. We all know what happened in 2020. But the great thing is, in 2021, we can see upward improvement there. And then we'll look into each specific core element. So this looks at the core elements from 2019 until 2022. We can see that leadership, accountability, drug expertise, and action were all kind of within the same range, 97, 98 to 100%. If we look at reporting and education, those were the 2 lowest, and we can see that there's been a slight decrease in reporting from 2019 to 2020. The largest decrease was in education from 2019 to 2020. So probably a lot less resources and time was given to education during 2020 given the pandemic. But it did gradually increase again in 2021 and then in 2022. This is a national figure, so to give you kind of a perspective of where Minnesota is. So the latest published data from the CDC's NHSN, this was back in 2018, and I think they'll probably publish data for last year hopefully soon, and it shows us that from 2016 nationally up until 2018, core element implementation increased from 43% to 71%, which was great progress. To remind you, at Minnesota here, in 2018, we were only at 47%. So we did make great increases, but in 2018, we were still lagging the national of 71%. So it'll be interesting to see after CDC publishes the latest data where nationally, where we kind of stand nationally. Now I'll just give kind of a quick brief view of the facility characteristics. Like I mentioned, we had about 146 facilities participate in our survey, and looking at the facilities by affiliation, most of them were multi-facility organizations. And by this, these are facilities that are part of a network of specialty facilities that share, policies, corporate leadership, and a common business structure. And so 45% of our respondents were multi-facility organization. And 83% of those implemented all 7 core elements. The second one there are the independent facilities. These are facilities that are not affiliated with a healthcare system or a chain, and only 75% of these facilities implemented all 7 core elements. The last here are the facilities that are affiliated with the healthcare system, and these had the highest implementation at 84%. But there were also the least amount of facilities, only 19 facilities, which is about 13%. And it's also important to note that when we looked at statistical significance, there was no significance. So on average, in Minnesota, we had 80% of facilities implement all 7 core elements. It's a little bit higher if it's a multi-facility or affiliated with a health system than if it's an independent facility. But statistically, that difference wasn't significant. Now, looking at nursing homes by bed size, on average, the average facility bed size for our surveys was 76 beds. Facilities that had more than 100 beds, there we had only 28 facilities, so this could not as large. That's about 20% of our respondents. They tended to do better. So larger facilities tended to do better in core element implementation, although it wasn't statistically significant. And then the next group, which was the largest group, from the 50 to 100 beds, we had about 50% of the facilities on that. 78% of them implemented all 7 core elements. And the smallest group, we had 81%. So there was no statistical significance either way, but larger facilities tend to do a little bit better. Where are these facilities located? So using the rural-urban commuting area codes developed by the USDA and using the zip codes, we found that 62% of these facilities are in rural areas. And when I say rural, these are facilities not in metropolitan areas. So the 38% are in urban. These are in metropolitan areas, with larger than 50,000, more than 50,000 residents. And the other were rural. There are subcategories to rural. I took those all out because there were no significant differences, just to make it kind of easier. But large town, small town, but still kind of considered rural. And when we looked at core element implementation, there was really no difference. Urban areas, 82% of the facilities implemented all 7 core elements, while in rural only 79%. So there's no difference there. Just looking at it graphically distributed there, we had 66 out of 87 counties in Minnesota. We had facilities from those counties, most of them being in Hennepin, and I'll kind of show you also a graph of the Hennepin facilities, then Ramsey, and then St. Louis. So what are the average infection prevention and control staff hours dedicated per week? On average, we had 23.7. And this is interesting to note because that 2018 study that I showed you from CDC nationally, the average was just 13. So we have a higher average here in Minnesota. However, here in Minnesota, the facilities that did implement all 7 core elements had 24 versus 21 for the facilities that not. So there is a difference. It's not statistically significant, but in the national survey, it was significant. And I think having kind of a larger, more respondents, a larger sample size, showed that infection prevention and control hours dedicated per week had a significant impact on implementing all 7 core elements. And when we looked at average infection prevention hours per week in terms of rural versus urban, there's quite a difference. It's 26.6 for urban and 21.8. Although if we went back to our figure, there was not really any significant difference between core element implementation. When we looked at the hours per affiliation, we saw that multi-facility organizations averaged higher than the others, and they did perform better, but not by a larger difference. This is a quick view about the Hennepin County incidence. Hennepin County being the largest county had the most amount of respondents and had the most amount of skilled nursing facilities. We had about 19 respondents from Hennepin County. That's about 34%, given that we have about 58, 59 facilities. Most of them were multi-facility organization. A third were independent, just about 10 health system. When we look at the bed size, it's significantly bigger. So these are bigger facilities, 120 versus the average of 76. And it's also interesting to note that for the average infection prevention control hours dedicated per week is 33.4 versus all of Minnesota, including Hennepin County, at 23.7. So we can see that they've dedicated a lot longer, higher resources than the others. And hence, they implemented about 95% of their facilities implemented all the 7 core elements, so 18 out of the 19 facilities. Now I'll give a quick view of each core element implementation, and looks like time, I'll try to go a little bit faster. So for leadership commitment, we had 92% of facilities said that they had a written statement of support from leadership that supports their efforts to improve antibiotic use. 98% of them had a written antibiotic stewardship policy. 62% said they had dedicated time for antibiotic stewardship activities in the leader's job description, while 73% of the leaders completed the CDC training on antibiotic stewardship. When we look at accountability, 97% of facilities identified one or more leaders accountable, and they were mainly medical directors, director of nursing, medical director, or consultant pharmacist. Drug expertise, 87% of facilities reported that they had access to an individual with antibiotic stewardship expertise, mainly being a consultant pharmacist trained in antibiotic stewardship, and 20% said they had an external infectious disease consultant. 60% of facilities had this expertise provided remotely, and within those facilities, 86% met all 7 core elements. So that's very encouraging and great to know that this could be utilized more in telestewardship to help provide drug expertise to facilities that don't have it. 85% facilities had at least one pharmacist engaged in the review and improvement of antibiotic use, and that review was done monthly in most of the time, and a third mentioned that they did this quarterly. When we look at action, we find that 89% of facilities have a policy that requires prescribers to document an indication for all antibiotics in the medical record during order entry. 2/3 mentioned that they use a formal procedure for doing a timeout for assessment 2 to 3 days after antibiotic start. 55% of physicians, 55% had a physician, nurse, or pharmacist review the course of therapy and provide feedback. So audit with feedback, that's 55%. And like I mentioned, studies have shown that to have, significantly reduce inappropriate antibiotic prescribing. And last, 45% facilities mentioned that they have guidelines for antibiotic initiation or selection. And we'll look at the tools utilized by these facilities. 64% mentioned that they utilize an SBAR while communicating with prescribing physicians. 60% said that they communicate antibiotic use information when residents are transferred. Just more than half give direct feedback to prescribers when prescribing does not meet the evidence-based criteria. 32% mentioned that they have a stool testing algorithm for suspected CDI, and just 16% said they utilize a facility-specific antibiogram. When we look at tracking, 98% of facilities reported that they track antibiotic use, and it's kind of split between half of facilities using days of therapy versus antibiotic starts. And when we look at tracking process, this here goes back to when facilities, so I can probably go back. So 89% of facilities, they track adherence to the policy that requires prescribers to document an indication for antibiotics. So 89% of facilities have a policy, and then within those 89%, interestingly, 89% said they document adherence to that. And then 83% document adherence to guidelines or recommendations. So if we go back, we have about 45% of facilities, they have guidelines and recommendations, and within those 45%, 83 monitor adherence to that policy. And when we looked at outcome measures, 70% of facilities reported that they track priority-resistant organisms such as MRSA and CRE. 63% said they track C. diff infections, and then 57% said they track other resistant organisms associated with HAIs. So how do they track? What are the tools that they use? Most of them, more than 2/3, use their EMR systems. About 40% use an Excel-based Excel-based, it's an infection antibiotic tracking tool that MDH developed to track infections and antibiotic use. Same amount mentioned that they just have their own tool that they have developed. Only 22% mentioned that they use proprietary or specific software, and only about 19% rely on the pharmacy report. And reporting, so 97% of facilities reported that they shared data in antibiotic use stewardship processes and or outcomes on a regular basis, with mainly 95% is facility leadership. And then we have consultant pharmacists and other providers. So most of the facilities that do report the data share it with this group. And the last core element, and this was the least core element implemented, which was education. So 89% of facilities reported that they provide education to either healthcare providers or facility staff. So to meet that core element, you should either provide education to the healthcare, so it's an either or. If we look at it separately, only 86% provided education for facility staff and only 50% for healthcare providers. And remember this and recall this, because when we look at the barriers and opportunities for support, it's mainly focused on education. So what information that these facilities provide? 65% said they provided education on core elements of antibiotic stewardship programs. 45% said it was on antibiotic resistance background, and 36% just alternatives to antibiotic use. They found that in-person meetings were the most effective routes of education, and then just quiz-based education and sending information via email and providing credit to and providing kind of educational produce that had CME credit. Now let's look at the barriers that were identified from these facilities. An overwhelming majority said that, I don't know if that's a bit small there, but 70% mentioned that there's pressure to prescribe antibiotics from residents and or their families. And this is important to know because studies were done, and this was mainly in outpatient settings, however, that they found that training in effective communication and training providers significantly reduced the amount of antibiotic prescribing. They were better equipped to communicate with the patients and their families. So that's 70% there mentioned that they had that as a barrier. 40% said that there's lack of awareness and commitment from healthcare providers. And again, lack of commitment and awareness, that also goes back, I think, to education. Only 50% of facilities mentioned that they provided education to providers. 36% mentioned insufficient staff time to work on antibiotic stewardship. We did look at the infection prevention control average hours. They were higher than average. Like I mentioned, there wasn't any statistical significance. However, having more hours and more resources, I think, would help specifically on tracking, reporting, and education. 27% said there's lack of prescriber accountability, and there's just only 10% mentioned that there's inadequate technology or systems capability. So what are the areas for support that these facilities had identified? About 40% mentioned that they want more, webinar-based education. So it does make sense that, more education for healthcare, for the providers, more education for the families, given that they kind of put a lot of pressure on prescribers to prescribe more antibiotics. A third said collaboration with other facilities to share and implement best practices. And I think this is really important given that multi-facility organizations and one associated with health systems tend to do better. Although it wasn't statistically significant, but they do tend to do better in terms of core element implementation. So they do share, common policies, best practices, and others. Quarter mentioned facility-specific protocols for diagnosis and prescribing, and resident education about proper antibiotic use, and in-person continuing education. So most of the areas of support are focused around education, and then I think that's something that MDH tries to provide kind of on a regular basis, opportunities for webinars and annual conference that provides CME and outreach to facilities. We have consultant pharmacists that reach out to facilities and kind of provide support. So to conclude, nursing homes, I believe, have reported substantial progress on antibiotic stewardship implementation, from 22% in 2016 to 80% now in 2022. It'll be interesting, like I said, to see what the national is once that data is published and where Minnesota stands. Improvements in access to drug expertise, reporting, antibiotic use. These probably reflect increased stewardship awareness since the core elements of antibiotic stewardship were released in 2015 for the nursing homes, 2014 for hospitals, and they started tracking them in 2016. So over the years, increased awareness, increased resources being located, and CMS requiring facilities to have infection prevention control programs and implement at a minimum antibiotic stewardship tracking and monitor use. And I think another thing would be important is to focus on education, communication, and collaboration. And I think these were the areas that were identified by the facilities, and we can see that education kind of has been logging for a certain time. And it looks like when facilities have less resources and less time, that kind of tends to be the area where it gets less prioritized. Communication training specifically for prescribers has been shown to reduce antibiotic prescribing. That's not necessary or optimal. And then also collaboration with other facilities to share best practices and implement them. And just lastly, implementing CDC's core elements of antibiotic stewardship is expected to reduce adverse events, prevent emergence of resistance, and lead to better outcomes for nursing homes. And with that, I'd like to open it up for questions. And I'd like to also, if anybody would want to share, best practices from their facilities, or what might be the hardest piece or core element to implement and why, and if there are any other challenges that we did not, or opportunities that were not mentioned here in the study.
We've reached time. Your current timing is perfect, so I just want to let people know if you need to leave at 1:30, please go ahead, and the rest of us will continue a conversation for 5 minutes.
Sure.
Thank you.
Thanks, Carrie. Notwithstanding the litigation that occurs in emergency departments in the country, I get that right. The bane of my existence, and I swear to God, if you're an old person in this country, you walk through an ER door, you might as well just say, here's my urine sample and where's my antibiotic, right? And I know that every nursing home in this country feels this pain, okay? I understand, the irony is that you can get an FTAG if you don't have an antibiotic stewardship program in a nursing home. Where's that same sort of pressure put on the emergency departments? I mean, you're saying that, if you're associated with an in-house hospital system, it's better, but that's inpatient. And ERs aren't really considered inpatient. I mean, I hear that MDH is putting pressure on people to say, look, that's okay, if you feel like they need an antibiotic, discharge them on 3 days and let the nursing home then follow up with the providers in the facilities to say, is this appropriate or is it not? But I've never seen that, ever. I don't know if anybody else has. Does anybody else?
And that's actually a really nice point to make. So for outpatient, and that's something we're actually currently working on, and we are going to be launching a survey this month for antibiotic stewardship in outpatient. So prescriptions in outpatient are actually more, and unnecessary, inappropriate prescribing for antibiotics for outpatient is actually worse off than in long-term care facilities and acute care hospitals. So prescribing in outpatient, it's different. They have CDC also launched core elements the year after for long-term care facilities for outpatient, and we want to see that. So we want to conduct a survey, look at core element implementation, focusing mainly on certain settings that we see and that studies have shown to have kind of higher prescribing rates, which are urgent care, family medicine, certain primary care practices. But for now, it's, I guess for long-term care, we're looking at the problems and how we can, I guess, offer certain support for
I
this.
just gave you the solution. Emergency rooms. And it's okay to prescribe because, it's litigious in that environment, right? But just to say, turf them out on 3 days. I mean, I saw a lady, 4 doses of Keflex with a GFR of 33 for 10 days for UTI. And I know this is something everybody in this room has heard of. But why is the pressure put on the nursing homes to meet a certain standard and yet they're not met for urgent care and emergency department? It's baffling to me. And I understand that you have your own process to work around, but I really believe that would really improve the outcomes. If you're saying that 30,000 people die every year from CF, and the reason is inappropriate antibiotic use, that's a no-brainer. You step into those environments and force them to do, like you force us to do, the appropriate antibiotic prescribing.
Yeah. So yeah, it was 35,000.
It's sort of a sore spot
Yeah.
for all of us.
Yes, I would understand. No, but that's really nice to know.
Can you tell us what the education for patients and families looks like that is referenced in this study? Because I feel like the responsibility falls to the provider to educate the patient and family what stewardship looks like. Does it come in the form of a printed handout that they give families, or?
Yeah, so we asked the facilities, they mentioned several things, printed handouts, posters, online education. But like you mentioned, providers giving the education was, and the study was done for outpatient, but it found that providers that received communications training to train and to inform and educate the patients had a significant impact on reducing that. But for our survey, we asked the respondents, like, how do you provide the education? I don't have it put here, but it was mostly through flyers, posters within in the rooms and things like that. You're welcome.
It's been really helpful to have an infection prevention nurse at a facility. I have a couple of facilities that have done that, and that person comes to me every time there's a new antibiotic in the house, and we verify that it's supposed to be there. So it's been really good.
Yeah, and having facility-specific guidelines and recommendations really does help a lot. Using low criteria, minimum criteria to be met, or using just national guidelines, but tailoring it to looking at if you have an antibiogram, you get access to that, which organisms and susceptibilities, that could also help a lot.
Do you think this study will be, you will resurvey the nursing homes again for MDH? Because you've got less than half of them reporting.
Yes, we do have less than half of them reporting, and we receive data each year through NHSN. So facilities, but even the data through NHSN is less. So for us to get half, so if you look at 2022, 146 for us, that was a accomplishment getting. If you look at the facilities that reported data through NHSN in 2021, it's only 71 facilities. And when you go back to 2016 it was only 55. So through our survey, we want to try to research as much as possible, and we'll try to do it yearly to monitor progress. And we also brought on board people that can provide technical assistance to these facilities. So within the survey, we asked, is there anything I guess MDH can do, can help? And so we're doing outreach. We have consultant pharmacists that are reaching out and seeing which ways that they can provide any technical support. Like I said, we also host a lot of educational events and webinars and conferences during the year. And according to the survey, we'll see what we have and what kind of education we can provide.
Thank you very much.
Thank you.
Do you have a minute to stay? I'm guessing there's more interest. Do you want, if